Very, very good evening. Okay, the first important concept. You can see my screen, right? My screen is clear, right? For you? Clear? Visible? Yes, okay. Okay, the first important concept is about the negative space. Okay, so negative space is seen basically in the buccal corridor. Okay, so normally whenever the patient smile, okay, there are two different types of smile, a normal smile and exaggerated smile. So whenever the patient is going for an exaggerated smile also, there are more than 25%, there are more than 25% of the patients where the gingival one third, okay, the gingival one third is not visible when the patient is going for exaggerated smile also. Okay, gingival one third is not visible. Why this gingival one third is not visible? Because of different things like the activity of the lip or the length of the lip or the amount of your alveolar bone. Okay, so there are many factors which are going to control the visibility. Okay, particularly it is about the lip thickness of the lip or the length of the lip is going to control that. Okay, so what is this? What is this negative smile? Is basically whenever the patient smiles. Okay, the patient smiles, there will be a slight gap that is present between the maxillary and mandibular teeth. That slight gap is the negative space, or you see that slight gap where you have the dark color. The dark color space is called as negative space. The dark color space is negative space. And apart from this, the negative space can be seen whenever there is a missing teeth. Whenever there is a missing teeth, okay, one, or whenever there is a diastema, or whenever there is a fractured teeth, or whenever a poorly restored teeth is there. So in all these conditions, you see this negative space. This is basically the dark space. Okay. For example, in this particular diagram, you can see this dark space. You can see the dark space in this buccal corridor area. Right? Can you see this? This is a dark space that is seen in the buccal corridor area. Okay. So the points to be noted is negative space is basically seen in the which area? It is seen in the buccal corridor area. It is basically the gap between the maxillary and mandibular teeth when the patient is smiling. It can also be seen in the case of mixed teeth, missing teeth, diastema, fractured teeth, and poorly restored teeth. Clear? Clear about the negative space? Okay. The next one is negative. The next important concept that I want you guys to make a notice. There is something called as dead space. So whenever you're going for a post and core, there is one concept called as dead space. Dead space in post and core. Okay. So what is this dead space in post and core? Can you tell me what are the different types of posts you have seen in your departments, in your colleges, or if you're working in a clinic or if you have your own clinic? Can you tell me what are the different types of posts you have seen? Yes, one is fiber post. Yes, most of us has seen fiber posts, right? Fiber posts, right? Fiber posts are regularly white in color. The second one, what we see is metal posts. Hope you have seen metal posts in the department. Have you seen metal posts? Sometimes the metal post will be gold in color. Gold coating will be there. Have you seen metal posts? Yes, right. So the concept is basically related to these two posts. Okay. So which posts are nowadays very frequently used? It is metal posts are frequently used or fiber posts are frequently used? Yes, perfectly right. The posts which are very frequently used nowadays are fiber posts. Can anyone tell me the reason why fiber posts are most preferred when compared to metal posts? Okay, aesthetics. Okay, aesthetics. That is not the main reason, but aesthetics. Okay, Aarti is telling aesthetics. Yes, it is white in color, so aesthetics. Okay, the main reason why you use fiber posts over metal posts is fiber posts are going to have all the properties similar to that of the surrounding dentin, because this is, if you consider this as a post, okay, this is a post, right? This is a post. And surrounding the post, which is present, the surrounding the post, you have dentin that is present. So what is going to happen is fiber post, apart from their aesthetics, how they help, the main important property of a fiber post is going to have all the properties, particularly the coefficient of thermal expansion, or when you're talking about the modulus of elasticity. So modulus of elasticity, coefficient of thermal expansion, and all the properties of fiber posts are similar to that of the dentin. So whenever there is a change in temperature in the oral cavity, how the dentin is reacting, fiber posts also react in the same way. How the dentin is expanding, fiber posts also react in the same way. For example, there is a stress. How the dentin is distributing the stress, fiber post reacts in the same way, transferring the stress to that of the dentin. You got it right? You got the reason why fiber posts are more preferred when compared to that of the metal post, right? Clear? Yeah. So that is the reason why we always prefer to have a fiber post. Okay. So what is the problem with a metal post? You see here in this diagram, you have a metal post. Okay. So what is the problem is metal post, metal is going to have more coefficient of thermal expansion than the dentin. So what is going to happen? Metal is going to expand more when there is a change in temperature when compared with the dentin, and it is going to cause more stress on the surrounding dentin that may lead to the fracture. Do you accept this? Metal is having more coefficient of thermal expansion. So whenever you heat it, metal expands more and dentin expands less. And this is going to create stress, and this stress may lead to the fracture in the future. Okay. So that is the reason why whenever you're looting metal post looting, okay, whenever you're looting the metal post, you have to leave some space, leave some space, because this space is going to compensate the expansion of the metal. So you have to allow some space, okay, so that the metal can expand in that space. That space is called as dead space. So that space is called as dead space. What is dead space in the post and core? You are going to allow some space for the metal to expand in the post and core system. That space, that extra space, whatever you're leaving is called as dead space. Clear, right? Clear, guys? Okay, now tell me, the concept of dead space in post and core is for option A, metal post, option B, fiber post, option C, both. What is your answer? Okay, right. So, right, correct. So dead space concept is only for the metal post. You're not going to leave any sort of dead space whenever you're going for the fiber post. Clear? And what is the advantage of fiber post over the metal post is fiber post is going to have all the properties, like for example, like coefficient of thermal expansion, or you're talking about the modulus of elasticity. All the properties are similar to that of the surrounding dentin. So how a fiber post is going to expand is almost same as the surrounding dentin. Okay, clear? Done? Okay, done. So then there is one more concept that most of us are familiar, that is called as dead space in respiratory system physiology. What is dead space in respiratory system? What is dead space in respiratory system? So dead space in your respiratory system is a place where gases exchange does not takes place. Okay, where gases exchange does not takes place. That space is called as dead space. No gas exchange. The space is called as dead space. So dead space in your respiratory system is basically of two types. What is that? Anatomical dead space and physiological dead space. Okay. Anatomical dead space is related to the anatomy, whereas physiological dead space is anatomical dead space plus area where gases exchange takes place previously, but now there is no gas exchange. That can be due to ACE, or that can be due to usage of some products or something. Previously, it is an area where gases exchange takes place, but now it is not. Gas exchange does not takes place. Clear? So anatomical dead space is anatomy related. Physiological dead space is anatomical dead space plus areas where gases exchange does not takes place. Clear? Done? Okay. Now, yeah, so areas, anatomical dead space is basically the upper volume of the the inner volume of the upper airways, that is basically the nose, pharynx, trachea, and bronchi. And these are the areas where gas exchange does not take place. So those areas are called as anatomical dead space. Whereas physiological dead space is anatomical dead space plus areas which are previously gases exchange, but now they are not able to exchange the gases. So that is called as physiological dead space. Can you tell me what is the normal dead space value in respiratory system? Normal dead space in respiratory system. Yes, the normal dead space in the respiratory system is going to be 150 ml. Is going to be 150 ml. Very good. Is 150 ml. Okay, so now you have a case in front of you. So can you tell me what is the Elise classification of this particular case? You can see a discolored teeth. What I can see is you can see a crack. I can see a crack. One is I can see a crack and I can see a discoloration. So discoloration is going to give me a hint that the etiology can be the necrotic pulp. So whenever you have Elise classification leading to the necrotic pulp, okay, non-vital teeth, the answer is Elise class 4, right? So tell me what is the treatment plan for this? Interns, post-interns, clinicians, what do you do? What do you do if such cases came into your clinic? Yes, first of all, we are going to do, because it's a necrotic teeth, okay, we are going to do a normal root canal therapy. Normal RC we are going to do. Yes, followed by why you want to go for a post-in core? Crown is where nice crown is there. No need of post-in core. Okay. So followed by you are going to do non-vital bleaching for this case. Okay. So once you're done with RC, so what you're going to do is you're going to remove the gatapacha 2 millimeters below the gingival recession or below the marginal gingiva. Okay. Then you are going to keep a barrier. So regularly, what barriers are used? You're going to keep a barrier so that the bleaching agent will not go to the root canal system. So what barrier regularly we are going to use in the non-vital bleaching? So what barrier we regularly use in the non-vital bleaching is GIC or modified GIC. And what is the material of choice for non-vital bleaching? Non-vital bleaching is basically done by? Yes, non-vital bleaching is basically done by a combination of sodium perborate plus hydrogen peroxide as an activator. Okay, sodium perborate plus hydrogen peroxide is basically used for non-vital bleaching. Clear, guys? Done? Can I move? I hope you are clear with this. Diagnosis of this case is you can see a crack and a discoloration that is basically due to the necrotic pulp, and the class and the diagnosis is going to be Elise class 4. Or if they're asking your like American Association of Endodontics classification, this is going to be necrotic pulp. Basing upon the radiographic features or clinical features, you have to diagnose the periapical area. For example, if the patient is having tender on vertical percussion for this case, so the diagnosis is going to be necrotic teeth with symptomatic apical periodontitis. Radiographically, apical changes are there, but symptomatically the patient is not having any sort of symptoms. Then it is going to be necrotic teeth with asymptomatic apical periodontitis. Okay. So now what is the treatment is you do an RC, keep a barrier, that is a GIC or resin modified GIC, you're going to keep it as a barrier. So once you're done with that, you're going to do a non-vital bleaching with sodium perborate and hydrogen peroxide in combination. Okay, right. Clear. So next is we'll have some important points. So this is basically metal ceramic. Okay, so you see metal ceramic crowns. Okay, now tell me what is the finish line of choice in metal ceramic crown? Metal ceramic crown, finish line of choice. Yes, metal ceramic crown has two finish lines, one on the labial or facial side, second on the lingual side. The better option for the labial side is going to be shoulder with bevel. Shoulder with bevel is the best option. If you don't have that, you can go with shoulder as an answer. And on the lingual side, the answer should be chamfer. Clear? Right? Clear? So it has two parts of finish lines. Labially, it is going to be shoulder with bevel, and lingually, it is going to be chamfer. Next, we'll try to understand few other important points that you have to make a note. Okay, right? So one of the major reason for acceptance of porcelain fused to metal is basically because of its greater strength and resistance to fracture. The combination of porcelain to that of the metal fused together is stronger than the porcelain alone, because porcelain is weak. Here it is stronger. And whenever there is a failure that is being happening, okay, the bond between the porcelain and metal is so strong, so that the failure mostly occur in porcelain only rather than the porcelain metal interface. Okay, so those are the important points. Next one, when you're talking about this porcelain fused to metal, the metal substructure should be 0.5, means the thickness of the metal should be at least 0.5, very frequently asked question. The minimum thickness of the porcelain should range from 1 to 1.5 millimeters. So what is going to happen? The total reduction is metal plus porcelain, that is 0.5 plus 1 to 1.5, which is total is equal to 1.5 to 2 millimeters, which is ideally 1.5 millimeter thickness is required. The most frequent cause of porosity in the porcelain is basically due to inadequate condensation of the porcelain. And that is basically due to the shape and size of the particles that are used. All these are MCQs. Okay, all these are MCQs. Right. Here, I want you to make one more important point. When you're talking about the coefficient of thermal expansion values, that is alpha values of metal and porcelain, metal should slightly have more value when compared to that of the porcelain. And as you know, porcelain is much stronger under compressive forces when compared to the tensile forces. So porcelains in all ceramic restoration should be avoided by keeping the preparations rounded. By keeping the preparations rounded. First important is metal ceramic crown, labial side, shoulder with bevel, lingual side, chamfer. Fractures can most commonly occur in porcelain rather than porcelain metal interface. Thicknesses of metal is going to be 0.5. Porcelain thickness is going to be 1 to 1.5. Total thickness is going to be 1.5 to 2 millimeters. Compressive strengths are more when compared to tensile strengths in the porcelain. So in order to prevent fracture in the case of all ceramic restorations, it is better you round off all the angles. The alpha value of metal is slightly more than the porcelain. Clear? Done? I'm going to the next concept. So next concept, slightly concepts related to smile designing. Okay. So can I know what is the percentage value that you have to make a note when I'm talking about golden proportion? So what is the value of golden proportion? Exact value of golden proportion? Yes, the exact value of golden proportion is 61.8%. 61.8%. So please do make a note about the scientist name also. So golden proportion is basically telling you that comparison of mesodistal dimension of lateral to central or central to lateral or lateral to canine or canine to lateral. That is visual, that you view from the frontal area. So this is basically the apparent mesodistal dimension, not the exact dimension, right? You got it right? This is not true dimension. It is apparent dimension, what is visible from the facial surface. So what is this telling? What is this 61.8? When you compare the mesodistal dimension of central incisor to the mesodistal dimension of the lateral incisor, okay, means for example, your central is 100%, your lateral will be 61.8%. If your lateral is 100%, your canine is 61.8%. I'm repeating again, this is not the exact mesodistal dimension. This is an apparent dimension, what you see from the frontal area. So what is visible? Because canine is slightly curved. So entire canine will not be seen. So whatever you see, that will be 68% of the dimension of the lateral. What you see lateral, that is 61.8% of the central incisor. Got it right? You got it right? If they're asking in the ratios, your answer should be 0.618. or 61.8%. Okay. So I'm done with the golden proportion. The main disadvantage of a golden proportion is talking about the apparent dimension, not the original dimension. That is the biggest disadvantage of the golden proportion. Now you have one more proportion. What is that? Red proportion. Red proportion is nothing but recurring aesthetic dental proportion, which is given by what? So what is this basically? Okay, so lateral by central is equal to canine by lateral. Canine by lateral. Got it right? So 2 by 1 is constant value. That is equal to 3 by 2 is a constant value. So that is called as red proportion. There is something called as M proportion, which is very, very frequently given in these examinations. M proportion is telling the width by length. The width by length ratio of a particular teeth should be 4 by 5. They're asking in percentages. You need to go for an answer around like 75 to 80%. Done? If you're done, please do respond me.